Hi, this is Martin Altersberger speaking for Heart and Lungs Ultrasound. In the previous videos of diastolic dysfunction, we already started discussing myocardial mechanics and some measurements. In the next couple of slides, I want to talk about the measurement of tricuspid regurgitation. That is a very important measurement. As you can see in the graphic, that left ventricular filling pressures translate to left atrial filling pressures into the pulmonary venous system, and then back also, of course, to the lungs, to the pulmonary arteries, then overall to the right ventricle, leading to elevation in right ventricular pressures as well. So the measurement of the TR velocity translates filling pressures from the left heart to the right. So showing that the patient has pulmonary hypertension in presumed elevation of filling pressures is a very important thing to do and gives you a lot of information about the left heart as well. So if it is measurable, it's an excellent parameter. But of course, it is very important. It is crucial to have an optimal angle, an optimal signal, and overall a measurability of tricuspid regurgitation. So the less volume is shifted due to TR, the more complicated and incomplete and worse the signal can get. So the less volume is actually shifted due to tricuspid regurgitation. So if you have only mild or even trivial TR, the more incomplete and worse the signal overall gets. So you need a certain degree of TR to actually measure it. And that makes it, of course, more difficult. It's not an easy measurement. Also in severe, massive, or even torrential tricuspid regurgitation, you cannot use it because the pressure gradient that can form is too little. So there is no real pressure gradient. So the sPAP measurement, so the measurement of systolic pulmonary arterial pressures we do via the modified Bernoulli equation, is actually not measurable. Also in severe right heart failure. So if you have a right heart which has a severely reduced function, also no pressure gradient can form. So the sPAP you are getting is also not usable. It's not really measurable. The right atrial pressures, they also can influence TR measurements, so lead to an underestimation of systolic pulmonary arterial pressures if they are truly significantly elevated. As we said, all parameters have limitations. In this case, you can see a patient with atrial fibrillation, but still you have this very nice signal. So you only want to measure the TR when you have such a signal, and you do not measure it at the very end of the signal. You do not increase gain, so I wouldn't do that everything becomes really yellowish in this area. So you really want to have a distinct measurement for tricuspid regurgitation. In this case, it's probably moderate. You can see over here, dilated right ventricle, even though the right ventricular function is reduced, and sPAP can be calculated in this area. So it's around 3.1 meters per second. Translating, of course, then into a sPAP measurement with millimeters of mercury. Be aware that due to the reduction in right ventricular function, here might be an underestimation still of this gradient present. So to summarize again, all the parameters we have limitations. The E to A ratio, the E to E prime. When you want to know more about it, go back to the videos prior. Also, of course, the left atrium has some difficulties in evaluation. We discussed it in the last video, and the TR measurement for me personally is sometimes very difficult. So it's 50-50 chance you will even get an optimal signal to really measure the sPAP, the tricuspid regurgitation signal. Keep that in mind and look for alternative measurements as well. The measurements we just discussed, they are not valid, especially in mitral regurgitation. So if you have relevant mitral regurgitation, so moderate to severe or severe MR, you cannot use those measurements because in this case, for example, you see that MR is already more than just moderate. You do see a certain vena contracta. You do see a formation of this dilatation of the annulus, the mitral valve annulus, due to probably left ventricular dilatation, but especially left atrial dilatation. You have a stretching of the mitral valve and here MR. And here you have the vena contracta. Here this piece, of course, this is not a measurement for PISA. and you have a somewhat eccentric jet over here. So when you have relevant MR, so more than just moderate, all the measurements for diastolic dysfunction have to be evaluated if they are truly measurable. So when you have MR, think about that it's not possible. Also in heart transplant, you have severe limitations, of course, because all the measurements we have are not really usable. In heart transplant, what is possible is, for example, if you have a TR, so tricuspid regurgitation, and a measurement of systolic pulmonary arterial pressures for evaluation of filling pressure. So that is still valid in heart transplant. The E to E prime ratio doesn't work, especially when the patients are freshly transplanted, and also left atrial volumetric index is more difficult. So in this case, you see here quite nicely patient with a heart transplant, and you see here the left ventricle, the left atrium, the right atrium, the right ventricle, and here we have an evaluation of this TR signal in a reversed 4-chamber view. So here you can see TR, and here probably you would be able to measure an sPAP and the TR peak signal. Furthermore, there are limitations in left ventricular assist devices. So all our measurements are not really valid when we have a left ventricular assist device. So here we have a patient with a LVAD, so a left ventricular assist device, you do see here, and here in the left ventricle, the LVAD. So here's the mitral valve, that's a peristernal long axis, that's a subcostal short axis. And what you have to evaluate before left ventricular assist device implantation is especially the degree of aortic regurgitation. So this device here helps sucking the blood, and the blood is then transported into the body via this device. Overall, we know that for the HeartMate 2 and 3, there will be an improvement of E to E prime, the pulmonary vascular parameters, deceleration time, LAVI, left ventricular and diastolic volumes, and left ventricular and systolic volumes as well. There will be a lesser degree of MR and also an improvement of systolic pulmonary arterial pressures. But we cannot really assess diastolic dysfunction in left ventricular assist devices. Even though, of course, and that makes sense, when you have a reduction in volume overload in these patients and an assist device which helps transporting the blood, of course, the heart has to show an improvement of several parameters denoting elevation of filling pressures, because naturally, when you assist the heart, filling pressures have to be lower compared to what they were in a decompensated stage or in end-stage heart failure. And of course, atrial fibrillation. Atrial fibrillation also shows a lot of limitations by means of filling pressures. Keep in mind that as soon as a patient has atrial fibrillation, the patient has a certain degree of diastolic dysfunction. So the diastole cannot be normal. So diastolic function cannot be normal. But on the other hand, it doesn't necessarily mean that filling pressures are elevated. And here is an example that E to E prime in atrial fibrillation does correlate with heart failure. E to E prime is better than the NT-proBNP and left atrial area if you want to see how filling pressures are actually in patients with atrial fibrillation. And E to E prime improves in patients with heart failure. So E to E prime in patients with atrial fibrillation, also with heart failure, of course, can be used. Keep in mind, the cutoff value is defined by a medial measurement. We will also discuss this in a later stage. One more thing for me personally, which I consider is quite interesting, we have several formulas where we can measure filling pressures. So here are 6 formulas, and we will try to measure them in several patients. For example, we have the first very easy formula showing pulmonary capillary wedge pressure. So actually filling pressures we can estimate with simply the E to E prime plus 4 equaling pulmonary capillary wedge pressure. The PCWP we can also measure with the Nagueh formula. So here I have 1.24 times E to E prime plus 1.9, like it's written here, and you also get an estimate of pulmonary capillary wedge pressure, which is left ventricular filling pressures and which also is equal to left atrial pressures if you do not have mitral stenosis or pulmonic stenosis present. Then we have the E to velocity propagation index that can show you left ventricular and diastolic pressure. So E to VP ratio above 2.5 denotes that left ventricular and diastolic pressures are elevated, so above 15 millimeters of mercury in patients with reduced ejection fraction. Another formula, now it's getting a bit more complicated, is 4.5 times 103 divided 2 times the IVRT plus the velocity propagation minus 9. That also can be used to measure and calculate left ventricular and diastolic pressures. Another formula, 90 minus 0.62 times the acceleration time of the RVOT, or the acceleration time of the pulmonic valve, so pulmonary acceleration time divided by the pulmonic shunt, is the mean pulmonary arterial pressures. And the IVRT divided by the time of E minus E prime also denotes if the ratio is below 2, that elevated left ventricular and diastolic pressures are present. So for that, you need, of course, several measurements and also timing by means of the ECG. So some formulas are quite straightforward, some are more complicated. Let's see in a patient, it's Peter, he's 32 years old and he definitely shows heart failure. So ejection fraction is reduced. It's a case of HFrEF, so heart failure with reduced ejection fraction. We estimated the F also with automatic measurements in the range of 25 to 30%. And he also did show a few B lines. So B lines you can see in lung ultrasound, and lung ultrasound gives you a lot of information also about filling pressure. So the more B lines you have, the more congestion you have. So some degree of congestion present, and he also had mild pleural effusions. So as we see Peter, let's start with some calculations and some formulas. Before we go on, I want to show you his strain imaging. In this case, you see all the loops we need for strain imaging, the 4-chamber view, the 2-chamber view, and the apical long axis view. We do see this region of interest, so these dots, and we see below the dots that actually how the left ventricle is being traced, and we can see how longitudinal function works in this patient, and it's severely reduced. So what we can see is a GLS of minus 6.5 that denotes a severely reduced longitudinal contraction, and we do know that strain should be in a normal range around minus 18 in young patients. He's 32 years old, in the range of minus 18, minus 20, even minus 21, minus 22%. Here also get an ejection fraction measurement, and you see 23% is similar to what we would estimate with ejection fraction being in the range of 25 to 30%. So this is a case of HFrEF. Furthermore, you have the bullseye. In the bullseye, you see the individual segments, and basically all the segments show a reduction in the longitudinal function. You can also eyeball this so you can see that longitudinal function, especially in the septal regions, is severely reduced. So basically here is no longitudinal function present. You see that there's a radial contraction and basically no longitudinal contraction. That you can see in strain as well. So especially in the septal regions, it's even more severely reduced compared to the anterior regions, where you can see there is a certain degree of longitudinal contraction still present. Now, we want to estimate filling pressures, we said. Here I have an evaluation of several automated measurements of the E to A ratio, and overall you can see here several measurements, and it's always in the range of around 3. So going a bit forward to evaluation of filling pressures by means of our guidelines, when you have a left heart disease, and in this case heart failure with reduced ejection fraction, shows with this severely reduced EF with the severely reduced strain, shows left heart disease. An E to A ratio above 2 denotes automatically elevation in filling pressures. And so this E to A ratio above 2, we already know elevated filling pressures must be present. Now it's quite interesting using the formulas. So we have said that this E to A above 3 shows this restrictive filling pattern, definitely elevation of filling pressures. And when we calculate the E to E prime in this patient, it was 12.4. If you use the first formula, plus 4, so E to E prime plus 4, gives us an estimate of pulmonary capillary wedge pressures. And actually they are not that high. So this is showing an elevation, 16.4 millimeters of mercury, is not normal, but overall, we would estimate, I would say, higher filling pressures. Continuing with the next formula, we said we have the Nagueh formula. 1.24 times you have the E to E prime plus 1.9 in brackets also equals the pulmonary capillary wedge pressure. And when we calculate this, we get a PCWP of 17.73 millimeters of mercury. So a measurement which is a bit higher. In the loop, you can see that there is small pleural effusion present, was on the left side and on the right side. So just for you who are not probably used to lung ultrasound, this is the pleural line. We have here small part of pleural effusion. So this black area, that's pleural effusion. Let's move on to the next formula, the next couple of measurements. It's now a formula where we calculate the E divided by the VP, so the velocity propagation. And if you get a ratio of above 2.5, it means that the left ventricular and diastolic pressures in reduced ejection fraction are above 15 millimeters of mercury. That's already very specific, but let's take a look. In this specific case, we have significantly reduced ejection fraction. We have an E wave which was measured with 83.8 centimeters per second. And you see the measurement of this M modes, the color M modes, the flow from the mitral valve 4 centimeters into the left ventricle. And there we have measured a measurement of the flow propagation of 30 centimeters per second, which is shortened. Now, when we divide 83.8 divided by 30, it's 2.8, meaning elevation in filling pressures in this patient with reduced ejection fraction is present. So the higher the E wave, which will be, of course, an elevation in filling pressures, and the shorter the velocity flow propagation, so more pathological, the higher the ratio will be, and the higher the ratio, of course, the more likely an elevation in filling pressures in patients with reduced ejection fraction is present. Again, it's a very specific formula. You need a very specific, sometimes difficult to perform measurement, the color M mode flow propagation, but just that you know it is possible basically to do. Again, one word to the color M mode. So you use M mode, first the color Doppler, you visualize the mitral valve inflow with color Doppler, you place the M mode in this region, and then you can calculate the color M mode flow propagation. The next formula is even a bit more complicated. It is 5.4 times, you see the entire formula there. You need the IVRT, you need the velocity flow propagation, and several numbers to calculate left ventricular and diastolic pressures. So we have calculated the VP for 30 centimeters per second. We have the IVRT, and you calculate the IVRT before the inflow of the left ventricle. So we have the E wave, diastasis, here we have even an L wave, the A wave, and then we have the IVCT, then systole, and then we have the IVRT. And when the IVRT is shortened, it also denotes elevation in filling pressures. And with this formula, we have now the numbers inside, and one quick word to the measurement of the pulmonary venous system. So we also can measure the pulmonary veins. So here you have an example where you see this patient, the left ventricle, the left atrium, and the pulse wave Doppler, we have to make the sample volume a bit smaller, so it should be 2 to 3 millimeters. Normally it's around 5 to 8 millimeters. And in this case, we do see an inflow into the left ventricle via the pulmonic veins, and we can calculate also ratios there. And this S to D ratio, so we have an S wave and a D wave, shows when it's below 1 that filling pressures must be elevated. Also, we can measure another time interval. We can measure the overall reflow, so the AR, and the time of AR as well. So we also can utilize more measurements as well. But continuing with this formula, I want to show you how to measure the IVRT again. So when you measure those, you have now the tissue Doppler signal. Before we had the pulse wave Doppler across the mitral valve. For timing, it's optimal to place the pulse wave Doppler in between the inflow and the outflow to see the intervals better, or simply use, which I personally prefer, the TDI measurements, so tissue Doppler measurements for the time intervals. And here you can see some measurements. Let's take a look here first. We have here the systolic part, so that's the S prime of the left ventricle. It's also reduced, it's in a range of 5 centimeters. Then we have the IVRT, and here we can calculate the first time interval. So before diastole, so the S prime and then S prime and then the E prime, we have this time interval, and that's the IVRT, so the isovolumic relaxation time that we can measure. Then we have the E prime that is followed by diastasis, and then the A prime as well. And then we have the IVCT and then the S prime again. So here we have all the measurements and all the time intervals we can identify. So showing it in another signal, we have the S prime, then the IVRT, E prime, diastasis, A prime, and IVCT, so isovolumic contraction time. When we now calculate this formula, we use this formula to calculate filling pressures, we get 17.47 millimeters of mercury. So very similar to the measurements we had before. Now, we also can measure time intervals in the right ventricle. So this is just an example of extensive measurements of time intervals in the right ventricle. And when you see a prolongation of IVRT, so the isovolumic relaxation time of the right ventricle, also an elevation of filling pressures of the right ventricle, so pulmonary hypertension, might be present. But continuing with another measurements, we also have this formula, and also in this formula, we see it displayed over here. The PCWP, so the pulmonary capillary wedge pressure, is elevated. In all formulas, we have to be aware of good punctuation. Now I want to continue and summarize some of the formulas we have seen. So in this patient, we can immediately agree that filling pressures must be elevated. Overall, we already started therapy. So there might be already a reduction in filling pressures present compared to how the patient initially presented to us. So all of them show a similar result, but not a result I would have thought we would see. Furthermore, all the formulas, they need various measurements and therefore have many pitfalls, especially when you have time intervals and the not optimal visualizations of the signal. So if you have a suboptimal TDI, it's definitely a pitfall if you cannot differentiate the IVRT properly. The range of, in this patient, the left ventricular and diastolic pressures and the pulmonary capillary wedge pressures was in range of 16.4 to 17.5 millimeters of mercury. But I want to show you more formulas for pressure evaluation. And here we have the next formula, and here you can see quite nicely a measurement of the pulmonary acceleration time. You have here the pulmonary acceleration time. You will use the pulse wave Doppler just below. So I always place it at the tips of the pulmonic valve, so that it's in this optimal angulation where blood really flows straight outward. And here you see the dilatation of the pulmonic trunk, so the common pulmonary artery, and here I have the right and the left pulmonary artery nicely displayed. And in this case, the pulmonary acceleration time in this most optimal signal over here is severely reduced. So by means of the pulmonary acceleration time, we have it here, 36 milliseconds is severely reduced. Normally, you're expecting 100 to 120 milliseconds. When you have a higher likelihood of pulmonary hypertension, it will be below 105. Overall, 80 to 100, 105 gives you already hints about pulmonary hypertension. 60 to 80 is a higher degree, so probably a more severe degree of pulmonary hypertension present. And if it's below 60, this might be a severe case of pulmonary hypertension. But in those formulas, we can also evaluate and compare the measurements. And we can also calculate mean pulmonary arterial pressures, which are, per definition, the measurements you need for defining is pulmonary hypertension present, in this case, most likely due to left heart disease. And when we fill this in this formula, you do see the mPAP we would get is 67.68 millimeters of mercury. So a very, very high value. If we compare it to our TR signal we had in this patient, we do see that it's not even 3 meters per second. The IVC was dilated, so we estimated the right atrial pressure around 15 millimeters of mercury, and calculating that together gives us almost 50 millimeters of mercury of the systolic pulmonary arterial pressure. Now, of course, we have divergent interpretation of these pressures because we have an sPAP, so the systolic measurement is around 50, but the mean pulmonary arterial pressure in this formula is even higher, so that's literally impossible. Keep in mind, all the formulas, they are estimates, so sometimes they are a bit off. In this case, the mean arterial pressure of the pulmonary artery is definitely a measure or shows a measurement error. The sPAP with 50 millimeters of mercury we measured directly, so this is most likely a more accurate measurement. Now let's go to the actual measurements we measured in the right heart catheter. There's a 7 days difference, I have to admit that, so the right heart catheter was done 7 days later. And when we take a look at our formulas that we see the pulmonary capillary wedge pressure, we can also see that in the right heart catheter measurement, the pulmonary capillary wedge pressure is not that far off from what we measured. So with heart failure therapy, of course, with decongestion, we do see that the PCWP measurements, they are relatively similar. When we look at the pulmonary artery, the mean pressure we calculated was definitely way too high. Also, the sPAP measurement was elevated or more elevated compared to what we actually measured in the pulmonary arterial system. So always keep in mind that the formulas can be used to identify elevation of pressures, but not always the individual numbers are truly what we can measure in invasive measurement. So the gold standard, of course, is an invasive measurement. So the teaching point here is measurements, formulas, they all are interesting and also important, I think, to understand and sometimes also to measure. But of course, they have limitation and of course it has to make sense. So also use all the information you can get in echocardiography to actually then define what the most likely situation is. Is a case of elevation in filling pressures present? Is the left heart disease responsible for pulmonary hypertension, or do we have to look further? In the next videos, we will continue, of course, with more measurements and more patient cases and evaluation of diastolic dysfunctions in our now current guidelines.